A CTO is a chronic total occlusion of the coronary arteries. In some ways, it can be very similar to those who have non-critical lesions, not occluded lesions. So a total occlusion is 100%. Anything less than that is a non-occlusion. And sometimes the symptoms are very similar, with chest discomfort or shortness of breath. But more often than not, it's fatigue or exhaustion with physical activities. They're just not able to do their usual, household chores, exercises. They just run out of gas. So 25% of patients who come to the cath lab have a CTO. And of that 25%, only 5% actually get their CTO treated. People feel it's very difficult to treat, as opposed to the non-CTOs, which are readily treatable with the standard guide wire technique. The CTOs, because they're 100% blocked, the guide wires that we usually use cannot penetrate through the occlusion. Also, with the CTO, we're not sure exactly where the artery goes because you can't see it. And so for these reasons, it's thought that they're very difficult to treat, and usually they're left alone. That was the initial thought, and the risk was high because as the wires got stiffer and stiffer to penetrate that blunt cap, it would cause perforations. And now the way we get around that to mitigate the complications is we do 2 angiograms at once. So we image the occluded artery and then the other side of it called the donor artery. By doing that, we get a very clear map as to where the artery goes that we cannot see past the occlusion. Now we're able to see it because we take a picture from that donor artery. We use 2 access sites, usually 1 radial and 1 femoral. So it's a little different. There's 2 access sites as opposed to 1, 2 guiding catheters. And the other thing that's very different, and what's been a big part of our success here, are 2 doctors. So myself and Dr. Bernardo were both co-directors of the program. We both scrub in on every case. We both review every case beforehand, map out our strategy, but we're both in it together. And these procedures can be long, 2 to 4 hours. And so it's good to have 2 doctors, especially when we're coming from different directions sometimes. It's very helpful to have 2 seasoned physicians doing this. For physicians, once we get the word out there, a lot of physicians have been going through the MedStar image share. Dr. Sattler has been fantastic about having patients referred to him, and then he forwards them to us, and then we call back the referring physician, and we get the details on their clinical condition and how to go forward. "35% of patients already had a bypass already. And so a lot of these patients really don't want to have another bypass. In usual fashion, the left inferior mammary artery to the LAD is open, and the RCA is occluded, and the vein graft to the RCA is occluded. And so then we work on opening up the native right coronary. The amazing thing is sometimes we go through the occluded graft to get to the occluded native, and then we externalize the wire and do the procedure. So we have a really good success using grafts, using the other arteries, epicardial collaterals, septal collaterals. It's very exciting. Very specialized equipment too. I mean, equipment for a retrograde procedure, you'll have a workhorse wire to get into the septal, and then a specialty wire to get through the septal, a specialty microcatheter to go through the septal. Once it's gone through the septal, then we switch back to another wire to get up to the point of occlusion, and then we swap that wire out for the wire to get through the occlusion of retrograde. Once we do that, we have another wire for externalization. So many steps along the way, and that adds to the complexity, and that's why it's good to have 2 of us there. The most rewarding thing has been the experience for the patients. So some of these have been my own patients that we took an angiogram of in 2010 before we started our program in 2015, I guess is when we started, 2015. And we thought nothing could be done. And now the patient came back and we said, well, something can be done now. And we open up the artery and they just say they never realized how limited they were. And what now, it's opened up a whole new world for them. So it's very rewarding to have somebody who has all this fatigue and exhaustion that we attributed to many other causes, but it was from that occlusion. They go home the next day and they really feel quite well. So it's very exciting. The patients have been tremendously appreciative, and it really fuels our enthusiasm for doing it.